Today we will discuss diabetic ketoacidosis, a few updates and a few pitfalls in its diagnosis and management. So essentially, the diagnosis of diabetic ketoacidosis is based on three things. As in DKA, the D stands for glucose, which should be more than or equal to 250 milligram percentage. K for the ketosis, there should be a blood ketone of more than 3 millimoles or a urine ketone of more than 2 plus. And A for the bicarbonate or the acidosis, the deficiency of bicarbonate, which should be less than 15 millimoles. So basically, across all societies, be it ADA, UK or AACE, the diagnosis is essentially depending on these three factors: the diabetic value, sugar value, the ketosis value, and the bicarbonate value. And when you look at the severity of diabetic ketoacidosis, it is graded from mild to moderate and severe. And these are dependent not on the absolute value of the ketones, but more so on patient's clinical situation. If the patient is alert, it is considered mild. If the patient is drowsy, it is considered moderate. And if the patient is in stupor or coma, it is considered to be severe diabetic ketoacidosis. Along with the clinical severity, we should also look at the arterial pH and serum bicarbonate, which divides the DKA into mild, moderate and severe. If the pH is between 7.25 to 7.3 and the bicarbonate between 15 and 18, it is considered mild, while at a pH of 7 to 7.24 and a bicarbonate level of 10 to 15, it is considered moderate. And when the pH is below 7 or the bicarbonate is less than 10, we consider it as severe diabetic ketoacidosis. Now conventionally, ketone bodies used to be looked in the urine. Nowadays, a lot of ketometers are available and you can do point of care blood ketone estimation. Each has its own merits and demerits. When you use a ketometer, the accessibility and the availability is an issue and the cost is slightly high, but you get the point of care values. When you use plasma ketones, the measurement is using a ketometer actually tell us for timely change in the management, and you can decide when you should go up in the management or come down in the management. But it's potentially painful and you need an equipment which is not always available. Well, when you use a urine ketone, it's more easily available and cheap and can be done, but unfortunately it takes longer duration for the urine ketone to become negative even after the correction of acidosis, and it measures only acetoacetic acid and not beta-hydroxybutyric acid, which is actually the primary ketone body in diabetic ketoacidosis, while the plasma ketone estimates beta-hydroxy. So there are advantages of each of these methods. Now when it comes to the diagnosis, always with the diagnosis you should identify what precipitated the decay. There is always a precipitating cause. Identifying the precipitating cause is of utmost importance, because managing a decay without identifying the precipitating cause, you wouldn't get the patient out of ketoacidosis fully. So let's see what are the common precipitators. It's usually the 5 I's: either infection, ischemia, infarction, or ignorance, that is poor compliance with the drug, or intoxication, either by alcohol or some other drugs, that are the usual precipitating causes. These precipitating causes may not be obvious at the time when the patient makes his presentation as a decay, and it may even masquerade the presentation. For example, somebody who is brought in comatose and diagnosed to have decay might have a myocardial infarction or stroke, while the comatose state will preclude the diagnosis of the underlying stroke or myocardial infarction, because the patient doesn't say of chest pain, because the patient doesn't say of the deficit. So always seek out for that, reassess the patient when the patient improves and see what are the precipitating factors. Because identifying the precipitating factor is always important in healing, in faster resolution of diabetic ketoacidosis, and also in preventing recurrent diabetic ketoacidosis from happening. So also at times, for example, if the patient has a myocardial infarction and diabetic ketoacidosis, without knowing the patient is having myocardial infarction, if you go for hectic fluid recitation, that can precipitate heart failure in the patient. So there are pros and cons. So always look out for a precipitating cause, and they are usually present in most of the people. Next thing, when you start treatment, what are the primary goals in treatment of diabetic ketoacidosis? The first and the foremost is correction of the fluid deficit. Next would be the correction of dyskalemia, which are almost always accompanies a diabetic ketoacidosis. And the third one is prompt initiation of insulin and titration of blood sugar. Remember, the control of blood sugar to normality is not the first or aim in managing a diabetic ketoacidosis. And then, as I told, identify and treat the potential precipitating cause. So the fluid deficit in diabetic ketoacidosis is to the tune of 4 to 5 liters usually. Then this should be followed by correction of the potassium. So once you start treatment, the patient's fluid status improves, urine output improves, the potassium changes. Initially there is a drop in potassium, so this should be anticipated, and you should give the patient enough potassium beforehand. So once you start treatment and the patient improves, when you decide the patient is out of DKA and when you decide on end of the treatment. So the end of the treatment is when the patient has improved significantly, his underlying respiratory cause has been identified and treated, and the blood sugars are falling down, and the pH is corrected to more than 7.3, bicarbonate has risen back to more than 15 milliequivalents, and the anion gap has close to the normal 12 milliequivalents. And of course, mental alertness and return to normality might lag a few days even after the correction of DKA. So that's not an absolute must to stop the treatment of diabetic ketoacidosis. Now, transition from an acute management to the IV management to the acute management, there should always be an overlap, especially in insulin treatment. There should always be an overlap of at least 1 hour from the IV insulin to the parenteral insulin. So if you plan to switch from IV to subcutaneous or IM route, give the subcu or IM route 1 hour before stopping the IV insulin, and ensure the patient is getting feed adequately when you are migrating from IV insulin to the other form of insulin. And always calculate the amount of insulin for today based on the requirement he had for the yesterday. Suppose he had 60 units of insulin yesterday, based on an hourly basis or 2 hourly basis, today he should also receive the same 60 units in a 3 or 4 divided manner. And always ensure hemodynamic instability, because hemodynamic instability can cause changes in the pharmacokinetics of insulin and may result in patient going back to DKA. Use long-acting insulin for basal requirement whenever the patient has been switched to 3 times insulin. Don't rely only on the plain insulin for control of sugars. Next, we will discuss some of the common controversies and pitfalls that we were having in the early management of in the early days of diabetic ketoacidosis management. So some of the yesterday's controversies have changed to be the norm of today. For example, measuring venous blood was considered a taboo in the early days of blood gas analysis, but nowadays it has become the standard practice in managing diabetic ketoacidosis management. There are some pitfalls in using venous blood gas because it may not reflect the PO2 correctly, but it does reflect correctly if you correct the bicarbonate and the pH. Then blood ketone meters, as I told earlier, has now become the point of care testing for diabetic ketoacidosis. Then 0.9% sodium chloride solution is recommended the fluid of choice in general ward. Don't go for complicated renal lactate or other half normal saline as the initial recitation fluid. Subsequently, after adequate fluid recitation, you can go for half normal saline if needed. Subcutaneous long-acting analog insulin or human insulin should be continued when the patient is in DKA as well. Coming to the difference between ABG and venous blood gas, although ABG is more accurate than venous blood gas for the assessment of oxygenation, when it comes to the measurement of PCO2, pH and bicarbonate, you can have minor adjustments and correct for the VBG compared to the ABG. So the usual correction is that when you take a peripheral venous blood for assessing the blood gas analysis, you don't expect the correction factor for oxygen, but you have a correction factor of say 0.02 to 0.04 more for a pH and a PCO2 of 3 to 8 millimeters more than the corresponding arterial blood gas. The bicarbonate would be again 1 to 2 milliequivalents less than the corresponding arterial blood gas. So if you apply this correction, you can get the corresponding APG. The advantage of using a venous blood gas is that you don't have to, it's a venous arterial blood gas is a difficult procedure, need talent and can result in hematoma. It's more painful to the patient compared to a venous blood gas estimation. So if you apply the correction factors, as far as diabetic ketosis is concerned, venous blood gas amply satisfies your need in estimating the approximate bicarbonate and PCO2 of the patient and the anion gap as well. Next is the priming dose of insulin. It was conventionally told that whenever you encounter diabetic ketoacidosis, you should initially give the patient 10 to 15 units of insulin stat and followed by infusion. Now of late, several studies have shown that this priming is not required and you can directly start with the infusion protocol of say 5 to 10 units per hour and then look at the blood sugar. The priming does not give any added advantage over this conventional insulin infusion protocol. The next controversy is, do you always need an insulin pump to manage diabetic ketoacidosis? Not necessarily. If the patient is hemodynamically stable, he can be managed on intramuscular insulins as well, provided you ensure that you check the blood glucose every time before you give to the next dose and patient is hemodynamically stable. The IM insulin does equally well. But don't go for IV insulin if you don't have a pump, because IV insulin has got a very short half of 7 minutes. So if you give an IV insulin every hour for 7 minutes he is having adequate insulin. For the next 43 minutes he is not having any insulin in the body. So he is going to go back into diabetic ketoacidosis. Now coming to the diabetic ketoacidosis in two special situations, especially patients who are on dialysis or in end-stage renal failure. First of all, diabetic ketoacidosis is a very uncommon situation in type 2 patients with end-stage renal disease, because in end-stage renal disease, insulin metabolism is impaired, because insulin is predominantly metabolized by the liver and the kidney. So when there is renal failure, the half-life of insulin is long, and along with that, the patient would be having usually sufficient fluid waterlogged in the body. Together with this, they are less likely to develop diabetic ketoacidosis. The only challenge in managing a patient with type 2 diabetic with chronic kidney disease and diabetic ketoacidosis is that you should be very careful when giving insulin. They require far lesser doses of insulin, or they may go for hypoglycemia. Also, fluid resuscitation can be greatly a challenge, because that can precipitate acute pulmonary edema in this patient. So usually you should go cautious, go slow, give lower dose of insulin and lower amount of fluid. The amount of fluid deficit in these patients are not such huge as we see in conventional diabetic ketoacidosis without renal failure. The next is pregnancy and diabetic ketoacidosis. Normal pregnancy itself, there is respiratory alkalosis with a compensated reduction in bicarbonate concentration. See, this bicarbonate concentration is already curtailed in a pregnant patient, so the threshold for development of metabolic acidosis is very much higher if a pregnant lady is diabetic and that diabetes is uncontrolled. This respiratory alkalosis can worsen and and can help in the faster precipitation of diabetic ketoacidosis. Then there is accompanying insulin resistance in pregnancy, which further predispose a patient with type 1 or type 2 diabetic to go for diabetic ketoacidosis. Aggravated to that, there is hyperemesis gravidae, which can still worsen the acidosis of the patient. Plus, administration of specific drugs like steroids and tocolytics in the last stages of pregnancy can precipitate a diabetic ketoacidosis because of the sympathomimetic agents predisposed to diabetic ketoacidosis. Also, euglycemic DKA are much more common in pregnant ladies compared to other people. The fluid resuscitation and insulin are as par with the other diabetic ketoacidosis management, but only additional thing, always consider IV thiamine in a pregnant lady with diabetic ketoacidosis, because hyperemesis would have made them deprived of thiamine, and you may precipitate a Wernicke's encephalopathy when you treat a patient with pregnancy with diabetic ketoacidosis without thiamine. Thank you.